Hello and welcome. On behalf of the National Eczema Association, I'd like to welcome you to this webinar on the topic of treating eczema with topicals. I'm Carrie Gauthier, Associate Director of Marketing and Communications. We see that people are still logging on and want to give them a few minutes to join us. While we're waiting, I want to make sure you all know about the upcoming activities here at NIA. Coming up on September 13th is our Complementary and Alternative Medicine presentation with Dr. Peter Leo. On October 1st we will be having our Leaders in Eczema one-day forum at Mount Sinai in New York. And October is Eczema Awareness Month. Registration is now open for the Itching for a Cure virtual walk, so go ahead and sign up. We'll give people a few more minutes to join us and then we'll go ahead and get started. Okay, it looks like we're ready to start. For those of you who have just joined us, welcome. I'm Carrie Gauthier, Associate Director of Marketing and Communications at the National Eczema Association. I'd like to welcome you to the National Eczema Association's webinar, Treating Eczema and Atopic Dermatitis with Topicals with Nurse Practitioner Susan Tofte. The National Eczema Association is a national, patient-oriented organization which is governed by a board of directors and guided by a scientific advisory committee comprised of physicians, nurses, and scientists who volunteer their time and expertise. We work to improve the health and quality of life for individuals with eczema through research, support, and education. The National Eczema Association would like to thank our sponsor, Aqua Pharmaceuticals, for their generous support that makes today's webinar event possible. As a family nurse care practitioner, Susan has special interests in atopic dermatitis, also known as eczema, inflammatory skin diseases, and is actively involved in clinical research studies within the dermatology department. With more than 20 years of clinical research and patient care in dermatology, Susan is a frequent national and international lecturer and has more than 20 professional publications to her name. She is active on many boards, committees, and national organizations. She has been on the Dermatology Nurses Association Board of Directors and held the role of president from 2007 to 2008. She is a past chair of the Nurse Practitioner Society of the Dermatology Nurses Association and has served on the editorial board of the Journal of Dermatology Nurses Association. Susan is the previous president and currently sits on the board of directors of the National Eczema Association, and she, along with John Hannafin, is one of the founders of this organization and has brought many years of skill, expert knowledge, and being a true champion for the community of eczema. Ms. Tofte will present for approximately 30 to 50 minutes. Please use the questions section to the right of your screen to send us questions throughout the presentation. Ms. Tofte will answer as many questions as possible after her presentation. Additional questions that we are unable to answer due to time will be answered to the best of our ability in a follow-up question and answer write-up and will be shared with all registrants. And with that, I am pleased to introduce our presenter, Nurse Practitioner Susan Tofte.
Thank you for that introduction, and welcome everyone to our webinar. I'm going to talk about the use of topical treatments in atopic dermatitis. And for many years, that was all we had to use. And I'll talk about some of the newer topical treatments that have come out. So just a little disclosure that I have served on advisory boards for several pharmaceutical companies. And you can go to the next slide. I don't have any financial investment in any of them. So I'm going to start by talking about goals for treating atopic dermatitis. And the three goals really are remission and then maintenance, so how to keep the disease stable and under control, and then how to rescue flare-ups. We know that this is a chronic skin disease and that flare-ups do occur. So I'll talk about how to manage to get those back under control. So inducing a remission is our first goal when we see patients in our clinic. So reducing inflammation, or literally I'll tell patients to put out the fire, meaning we'll talk about ways to reduce the redness, the itching, and just the chronicity of that and that cycle of flaring. And then how to maintain control in a safe, long-term way. And then again, rescuing the flare-ups, quickly treating and getting the disease back under control. Next slide. So first, a word about bathing. There can be a lot of controversy about that, particularly with young or with parents that have young children, pediatricians telling them to bathe for 5 minutes every other day or twice a week. And we get some patients who are just taking quick showers in and out. So there's some controversy about bathing versus not bathing. This is a skin disease where the barrier is impaired, and the barrier or outer part of this, the most external layer of the skin can't hold water. So and there's a lot of research that's gone around that. This talk is not going to go into that, but we know that patients with atopic dermatitis have severe dryness issues and their skin just has a hard time holding on to water. So bathing is good for your skin. It hydrates the skin, it cleans and debrides the skin. It can be a relaxing time especially for parents and young children. It can be a relaxing time for an adult to soak in a tub. And swimming can be a great substitute if the bathing time becomes a fight between parent and child. I'm going to just briefly mention, because people ask about chlorine in water of swimming pools. And chlorine, if you think that it's drying or irritating to your skin, then definitely shower when you get out, but the actual water on your skin is probably going to be a benefit. And then I'll talk about what we do immediately after bathing to prevent the dryness. So next slide. One of my colleagues, Dr. John Hannafin, who is world renowned for his knowledge and research in atopic dermatitis, coined this phrase many years ago, that errors in bathing and moisturizing are by far the most common cause of persistent atopic dermatitis. So it deserves a little showtime here to discuss how best to use bathing to your advantage and to use it to hydrate your skin. Next slide. So it is a bit of a paradigm that bathing dries the skin. That is true, that when you wet the skin and allow it to evaporate or dry immediately, it causes the stratum corneum, or that outermost layer of the skin, to contract and dry. It creates little cracks and fissures in the skin, impairing that epidermal or outer layer of the skin. But bathing also helps the skin. This is also true if a moisturizer is applied within 3 minutes to retain hydration, so trapping that moisture in, helping the barrier remain intact and flexible. So bathing for 20 minutes until the fingertips get wrinkly in a warm or cool bath is actually a really good treatment for patients with eczema and atopic dermatitis. Next slide. I use this slide not to promote any of these products. I don't have any special bias toward any of them, but really just to show you that moisturizers that are best are moisturizers that are creamy or greasy. And I lined these up in this way to take this picture because really to show that you can get moisturizers that come in large 1-pound jars. And I like these because you don't run out of them quickly. And for patients who have really mild disease, sometimes this is all you need, is just to hydrate the skin and then seal that hydration in with one of these creamy or greasy moisturizers. We try to tell patients to steer away from things in pump bottles and go for something that you actually have to scoop out of a jar. The things in pump bottles tend to be lotions, not creams and not ointments, and they tend to have more water and alcohol in them, so they might even be more drying than moisturizing. So pick one that you like. None of the moisturizers that we ever recommend have any kind of fragrance or perfume in them. So something non-fragranced and something in a quantity that you won't run out easily. So these are just some examples of ones that we've had in our clinic. Next slide. This is a slide that from my colleague, Dr. John Hannafin, and it's just really to demonstrate, this was a baby with really severe atopic dermatitis. You can see the redness on the abdomen and on the legs, but the one area of clearing on this little baby is in that groin area. So this is a very old slide, and this mom had been using cloth diapers, and the moisture that stayed next to that child was the skin that stayed the most clear, whereas the other areas that were not as well hydrated were the ones that were flaring. Next slide. So I'm going to move on. One additional thing I just wanted to say about moisturizers is, again, to emphasize applying them within 3 minutes of getting out of the bath or shower. So that usually means if you have a child that wants to run out of the tub, you need to close the bathroom door and keep them in there. And so just barely patting that excess water off the skin, leaving the skin feeling moist, and putting the moisturizer on immediately before they have a chance to get out of the bathroom and out into the rest of the house. I'm going to talk about topical corticosteroids. For decades, this is really all we had to treat atopic dermatitis. But you need to know how much is appropriate and how often to apply and what kind of strength. So I'm going to talk about the different types of strengths of topical corticosteroids and a little bit about quantities. Ointments are preferred, and then you really want to have the conversation with your provider about how to safely use it so that it's not overused and doesn't give you side effects to using in places that are inappropriate. So I'll go to the next slide. There are different classes of topical steroids. There's a handful of high potency topical steroids. One of them, generic name, is clobetasol. I do prescribe clobetasol mainly for thicker skinned areas on the hands and the feet, the wrists or the ankles where the skin has gotten thicker. There are a ton of mid-strength topical corticosteroids. Triamcinolone is one that is very commonly used. Some of you may have had that prescribed or may be using it. Betamethasone is another one. So many, many mid-strength steroids. And then there's a handful of low potency. These would be hydrocortisone 1% is one that you can buy over the counter. It's marketed under names of Cordate or Cortisone 10. Desonide is a prescription one and also very low potency. So if you are prescribed multiple topical corticosteroids, you want to be sure that you know which one is the high potency, which is low, which is mid-strength, and where are they safe to use. I like to try to stick with the mid-strength for all areas and limit the amount of days that can be used in certain thinner skinned areas. I'll talk a little bit more about that, but there can be some confusion, so be sure that your questions are answered if your provider prescribes more than one topical corticosteroid. Next slide. A word about vehicles, or basically the base that the medication is compounded in. So ointments are greasy. They're like a Vaseline type base, and that's preferred for patients with eczema and atopic dermatitis. It just gets into the skin better. Most patients will ask for that because they know that they get more benefit from it and it's more compatible with their skin. Creams are acceptable, but they may be more drying and they have more preservative in them, so sometimes they're a little bit irritating. Sometimes using a combination, maybe a little bit of ointment and cream mixed together might give you the right consistency that works better for your skin. There are corticosteroids that are in foam. They're similar to a mousse hairstyling product, so they're a really good one to use if you have inflammation in the scalp. Lotions are also a beneficial one, more liquidy, used in the scalp. And then solutions are really more watered down liquid things I've used in dropping into the ears if there's a problem with the external ear canal, or for the scalp as well. Those more liquid products tend to not feel as greasy in the scalp, and patients find them to be more compatible with applying to hairy areas. Next slide. Another topical treatment that many of you have probably heard of are the calcineurin inhibitors. They were the first treatment that we had come along in decades since topical corticosteroids had been approved. They are non-steroidal and they are anti-inflammatory, as topical corticosteroids are. They don't have the side effects of steroids. They've been FDA approved for children ages 2 and older. So Protopic, or tacrolimus, it is an ointment vehicle, so the greasier Vaseline type vehicle, and it is FDA approved for moderate to severe atopic dermatitis. There are 2 strengths. The 0.03% is approved for ages 2 to 15, and the 0.1% is FDA approved for ages 15 and older. Elidel, or pimecrolimus, comes in a cream vehicle. It has 1 strength, and it is FDA approved for mild to moderate atopic dermatitis, again for ages 2 and older. Just a brief word about the black box warning, which some of you may have heard about. The black box warning came issued by the FDA after Elidel became approved, and there was a flood of direct-to-consumer marketing. So in essence, it was being overprescribed, and there were some cases that came in that were reported of lymphomas, not with these topical agents, but with Protopic in the oral formulation is called Prograf, and it's a medication that is used as an anti-rejection drug for kidney transplant patients. So in their animal studies, using that in very high doses, there were certain cancers that got reported, and there just became some concern about whether or not these drugs were associated. They've never found causality between the use of these topical treatments, Protopic and Elidel, and skin cancers or any kind of cancers. But the black box warning stuck, and it's there. So if you have questions about that and your provider prescribes these, you should have that conversation with them. Next slide. The calcineurin inhibitors, unlike topical corticosteroids, can be used safely around the eyes, mouth, and genital area on a long-term basis. Topical steroids in those more thin skin areas, the upper eyelids, the face, neck, breasts, underarms, buttocks, and groin area, those are thin-skinned areas on all of us. And although you can use topical corticosteroids in those areas, you need to really limit the use there. So once those areas become clear, if the eczema continues to flare or begins to flare again within a couple of days, calcineurin inhibitors are a really safe and good choice. They work best again where the skin is thinner, such as face and neck, upper eyelids. They can be used in those thicker, more lichenified or the really kind of leathery skin that's gotten really thick from rubbing and scratching chronically. However, it takes longer to get through. Probably would need to use it for a prolonged period of time, applying after the skin is moist. And then because this is an immune modulator, Skin cancer is a theoretical risk. So I just tell my patients, regardless of what kind of medication they're using or what their skin type is, to always use sunscreen. Next slide. And then another word about it and information about that. Again, generally, it's best to reduce the remission with induce a remission and get to that point where the skin is better controlled with a topical steroid. And I have some examples of how to do that. And then try to maintain with a calcineurin inhibitor if something is needed long-term. Burning and stinging is possible, and it's an expected side effect. Generally, this lasts just for a few days, but I always spend a lot of time talking to my patients about that because it can be very alarming if you get this burning and stinging. Maybe some of you have experienced that. And I generally tell patients, my adult patients, I would say that it lasts between 4 and 7 days, and then the skin just acclimates and it tends to not have problems with that kind of a side effect. Other possible things are a flushing sensation when sun hits the skin where the medication has been applied. It doesn't make you sunburn easier or anything like that, but you can feel kind of a flushy sensation. And then the cream vehicle or Elidel might be a more preferred calcineurin inhibitor if your skin is prone to acne, or perhaps using the cream Elidel on the face and the Protopic on the rest of the body. Some kind of combination of that might benefit. Next slide. This is an example of a young child who has, you could see around the ankles and the tops of the feet, the skin looks very thick in those areas where it's kind of ridged. She has rubbed and scratched her feet excessively because she's so itchy. This would probably not be a great time to be using the calcineurin inhibitors, even though they're very safe and she certainly could benefit from them. But for a child like this or an adult whose skin looks like this, I would first use a topical corticosteroid, get this settled down, and then in those areas that are a little bit open on her ankles, it's going to hurt to put almost anything on there, but get this settled down first. And then once the inflammation is better and the skin doesn't look or feel as thick as it does now, the use of a non-steroidal anti-inflammatory would be beneficial at that point. Next slide. And I put this slide in as an example of really inflamed skin on this child. This is probably a case, again, where I would use a topical steroid to get the inflammation settled down. Maybe it would take about a week using a topical steroid after a bath, a soaking bath, get the redness down, get those open areas healed up, because putting the Protopic or Elidel in that area, especially those open areas, may really cause excessive burning and stinging. It's going to be very uncomfortable for a while. So to divert from that, I would use a topical steroid, get it under better control, and then maintain it with a calcineurin inhibitor, either Protopic or Elidel. Next slide. So ways of mixing and matching, if you will, would be to, again, our goal is to induce a remission. So getting the skin under the best control with a mid to high potency steroid twice daily for 7 to 21 days. And obviously I wouldn't use a steroid on the face for 7 to 21 days, but maybe for 3 to 5 to settle it down. Generally, the other areas of the body where the arms, legs, again, hands and feet, those thicker skinned areas may need treatment for up to 2 to 3 weeks. Once the skin is more settled down, the flare is under control, then starting use with a topical calcineurin inhibitor twice daily, probably for 2 to 4 weeks, to maintain that control. And then, you know, as you can taper down, always using moisturizing creams and ointments after baths or showers, and maybe getting down to only using one of those medications 3 days a week or something along that line. Alternatively, if you can maintain control by using topical steroids twice weekly, that's a really safe way long term. The studies have been done that showed cortisol levels were tested in young children, and the trials followed children for a year, and they found that they were quite safe using a mid-strength topical steroid twice weekly. So I usually just say to my patients, use it Tuesday and Saturday, and all the days in between use either a moisturizer or one of the calcineurin inhibitors. And that seems to be a good way to maintain in a very safe way. Next slide. So again, twice weekly use of a mid-strength steroid is safe long-term. For those patients who are more severe and their flare-ups maybe are a little bit unpredictable, use of a topical steroid 2 days a week, and again, 3 days a week with Protopic or Elidel or combination, and then always using proper bathing and moisturizing. When the skin is really well controlled, a tub bath might not be necessary, so showers are fine during those times. Never getting out of the bath, swimming pool, or shower without having your moisturizer ready to put on. Some patients ask about use of a moisturizer over the top of medication, and I try to steer patients away from that. The idea being that you don't want to dilute your medication. So if you're going to put topical steroid on, and that you might only need it in a few places that just tend to be persistent and more chronic, and then all the other areas using just a moisturizer. And if you feel that you need a moisturizer on those areas, you know, waiting 30 to 60 minutes so that you're not going to dilute the effect of the topical steroid, that would be fine as well. Next slide. So I like to use this slide because I think you can probably go to the next slide. There's another part to this slide. Can you?
Yeah, I apologize. It's not showing correctly on the screen.
Well, I can go from this. So I like to use this slide as a to show that some patients, and rightfully so, are looking. There we go. There's part of it. I think it's coming. There we go. Okay, thank you. Some patients turn to alternative therapies, understandably so, feeling that they are looking for other answers. This is a very chronic disease. The flare-ups can be unpredictable. It's frustrating. So it's very understandable looking for an alternative therapy. And this happened to be something that a patient traveled overseas. This is either Chinese or Korean, I'm not sure which. And we were able to get a, and the point being that they were feeling that they were using an alternative treatment that was safe. And we had somebody translate with this, and this fluocinolone is a mid-strength steroid. And so it's, these can be deceiving and dangerous over the long haul. So I would caution anyone, although I embrace wholeheartedly alternative treatments, and there's certainly a stage for that, but I would caution you about using something that's that is recommended as a treatment for atopic dermatitis, and you maybe don't know what the active ingredients are. So I would just be very cautionary about that. Next slide. So rescuing flares, because we know, again, this is a chronic disease. It doesn't mean you're doing anything wrong. It just sometimes takes on a path of its own. So I like to use a lot of my time with patients to educate parents and patients that atopic dermatitis is a chronic disease. Flares will occur. And when flaring happens, going back to the basics with vigorous therapy, going back to what you know, bathing twice a day, applying your moisturizer, topical steroids, the non-steroidals. And if the flare doesn't come under control, then come in. Don't let it get out of control, but really come in so that you can get the help that you need. Next slide. I'm going to talk a little about one of the newer products that have been recently FDA approved, Eucrisa or crisaborole. It is another novel non-steroidal topical ointment. It is an anti-inflammatory phosphodiesterase or PDE4 inhibitor. It's FDA approved for mild to moderate atopic dermatitis in patients ages 2 and older. Next slide. I like this slide just to demonstrate that a normal immune cell has a normal amount of phosphodiesterase, and then it produces these cytokines, which gives normal amounts of inflammation to the skin. Whereas a cell with a patient with atopic dermatitis produces excess phosphodiesterase or PDE and produces more cytokines, and those cytokines are responsible, they're proteins responsible for causing inflammation, redness, itching, and that whole cycle that makes a flare up with atopic dermatitis so miserable. So crisaborole or Eucrisa blocks the phosphodiesterase and prevents this excess of cytokines, and so it can block that inflammatory cycle. Next slide. The take home in this message or in this slide is that after 4 weeks of treatment, the body surface area that was involved decreased by 78%. So they enrolled children ages 2 to 11. They had to have 35% or greater body surface area, and ages 12 to 17, 25 or greater. And they found that after a month of treatment, the body surface area in both groups decreased by quite a large margin. Side effects, again, like the Protopic and Elidel, are burning and stinging. So warning, getting adequate education about that is useful. Next slide. So in spite of your best efforts, you're doing all the treatment regimens, you're doing all the right things. What flares atopic dermatitis? Well, we know that dryness or desiccation, not getting the skin moisturized after hydration, can cause a flare. Viral infections, and as we head into the fall, winter months, the cold and flu that will come on, especially for children, they can be triggers for a flare. Bacterial infections, most commonly staph infections on the skin or impetigo, can cause a flare. Emotional stress, we all have that, and that can certainly play a role. And for some patients, they notice that change of seasons, winter and spring, going from summer into winter or fall into winter, can cause flare-ups. So just being aware of those things. Next slide. So I just wanted to show a demonstration of these are intact pustules. You can see these little white bumps on the skin around the hair follicles. That's a staph infection. And so a staph infection like this can cause the skin flare to keep going. So I encourage patients, if they see particularly 3 or more of these pustules on the skin, to your topical steroid, your topical treatments are probably not going to halt this flare, so go see your provider and probably needs an antibiotic. Next slide. And then again, this is kind of subtle, but on the right back of this patient, you can see a very faint pink or red kind of circle on the skin. This is a patient with atopic dermatitis over his whole body. He was doing all the right things, using his treatments appropriately, and he couldn't get his flare-up under control. And this is a fungal infection that was pretty subtle. And once we treated that infection, his skin came under much better control. So be aware of your skin and knowing when, questioning when you continue to have a flare-up in spite of your best efforts, why that might be happening. Next slide. Other reasons for treatment failures, maybe not following or being compliant with your treatment plan, and that might be not understanding it. Psychological factors, again, stress and depression, resistant staph, herpes. There's a whole host of other things that may cause problems and cause a flare-up to continue. Next slide. Misunderstanding, again, or non-compliance of the treatment regimen, and just basically what I just said, untreated infections, viral infections. Sweating and exertion can sometimes pull this on, and so patients that work out at the gym regularly, showering afterward, having your medications with you in your gym bag, even excusing children from doing PE if that tends to be a trigger for them. And then in really remote cases, maybe thyroid disease needs to be looked at. Next slide. Parents of children with atopic dermatitis frequently lack sufficient information about the disease and the treatments. They may hold incorrect or harmful beliefs about these issues. So what I think of first is that some parents, well-meaning parents, but might be withholding, making dietary restrictions, thinking that the food is causing this problem. So really getting well-educated, demand time with your provider, and have a clear treatment plan. Next slide. I need to address topical steroid addiction syndrome and topical steroid withdrawal syndrome. And the way I'm going to address both of these issues is by reading from the Journal of the American Academy of Dermatology and National Eczema Association Task Force publication. The National Eczema Association has received increasing numbers of patient inquiries regarding steroid addiction syndrome, coinciding with the growing presence of social media dedicated to this topic. Although many of the side effects of topical corticosteroids are addressed in guidelines, topical corticosteroid addiction is not. Topical corticosteroid withdrawal is likely a distinct clinical adverse effect of topical corticosteroid misuse. Patients and providers should be aware of its clinical presentation and risk factors. Next slide. The American Academy of Dermatology poster, which was authored by Dr. Tim Berger, a dermatologist at UCSF in San Francisco, and Pam Friedman, who is with ITSAN, the International Topical Steroid Addiction Network, presented this poster. Topical corticosteroids have been the mainstay of treatment for inflammatory dermatoses and are felt to be safe when used appropriately. And I want to emphasize that, are felt to be safe when used appropriately. In response to increased reports about red skin syndrome and topical steroid addiction withdrawal, a systematic review conducted by the National Eczema Association concluded that red skin syndrome, topical steroid addiction, and topical steroid withdrawal is a potential adverse effect of prolonged use of topical steroids. The phenomenon of red skin syndrome, topical steroid addiction, and topical steroid withdrawal has been deemed rare. There is no validated definition, no patient registry, and no evidence-based treatment. Large numbers of patients who have used topical corticosteroids believe they have symptoms related to their use. In this cohort, the symptoms were reported as severe and persistent. As previously reported, longer duration and intensity of use of topical corticosteroids is significantly associated with more severe and prolonged symptomatology. Further study is needed to arrive at an accurate definition, diagnostic criteria, and prevention and treatment strategies for red skin syndrome, topical steroid addiction, and topical steroid withdrawal. If you feel that you have experienced something like this, I strongly urge you to have that discussion with your provider, present your concerns, go through your treatment regimen again, look at what's helped and what you feel has perhaps hindered your healing and obtaining that control, and look at what the options are. There are other treatments available now. Thankfully, this is a great time for eczema, and there's way beyond topical treatments. We have other treatments for severe patients, but it needs to be an open discussion with your provider with regard to this. I think that's the end of my talk. Next slide.
Yes, thank you so much, Susan, for an educational and informative presentation. We will now move on to the question and answer portion of our event. A lot of great questions have come in. While we can't get to every question, we have selected some of the most frequently asked questions from today's attendees. So I am going to start with, Susan, what is your favorite anti-itch, anti-pruritic topical treatment?
That's a great question. I would be cautionary, I guess I should say, about using those, just because many of them contain, the ones that are over the counter, things like Sarna, it's an old remedy. It's been around for decades. It's an anti-itch topical treatment over the counter. There are others that I think that Eucerin makes one. They generally contain menthol, and if you can tolerate that, it's fine. But patients with big flare-ups or severe involvement may not be able to tolerate that aspect of it. So I don't usually recommend those anti-itch things for patients with atopic dermatitis. And if you did want to try them, it gives temporary relief for a little while. And I would suggest putting it on a small area of your skin without spreading it too extensively before you try it over a large body surface area.
Great, thank you. You mentioned applying cream within 3 minutes of showering. Is this when topical steroids should also be applied, or any of the other, if they're using a calcineurin inhibitor or any of the other topical treatments?
Great question. And yes, the topical steroids should be applied within 3 minutes. The calcineurin inhibitors, you might be able to wait a little bit, because putting those on wet skin, unless it's fairly clear skin, it might burn more. So that would be my only cautionary note about that. But otherwise, yes, I tell patients to have their topical steroid open on the bathroom counter, ready to go. And the same thing with those moisturizer jars, open and ready to go. So when you step out, it's just a matter of patting the excess water droplets, and then while there's still some moisture on the skin, applying your topical treatments.
Great. What do you think of barrier creams?
Those are the ceramide-based creams, and I think they definitely have a place. One of the ones on my slide showing those moisturizers, CeraVe, I believe is considered a barrier cream, and I think those are fine. I think that they work just well. They work just fine, and it's kind of probably a personal preference as to what feels best on your skin, but I have no objection to that.
Great. We just had a question come in that someone has had atopic dermatitis their whole life, and they've experienced that when they go in to talk to their dermatologist, they are quick to prescribe topical steroids, but don't take the time to talk about possible causes or triggers. Can you maybe talk a little bit from your perspective as someone who treats these patients coming in, and how to address that trigger versus treatment question?
Sure. So I agree that I think that many patients with any chronic skin disease get pushed through the clinics probably too fast. I work at a university setting, an academic setting, so probably we're allowed a little more time with patients, and I think you deserve that. Any of you that have atopic dermatitis, you deserve the time. It might be helpful to have a list of questions ready when you go to your provider so that you have your questions ready when they come in the room, and addressing specifically things that you might think might be triggering. I focus on good skincare because some patients and parents focus on food allergy, and although you can have allergies that you can have allergies to things, it's generally not what causes widespread eczema, so keep that in mind. And so focusing on good skincare is better. Triggers, as I went through some of the things that we know flare, infections certainly will flare skin and keep it kind of percolating along. So being aware of that. Most patients with atopic dermatitis steer away from fabrics that are too warm. I tell parents of little children not to put their babies that have eczema in those fleece sleepers, and to use really lightweight bedding and clothing, probably staying clear of wool and those types of fabrics. Those are triggers. You just kind of have to know your own body, but I would find a provider that will listen and take the time and give you the time. And if you don't get your answers, find somebody who will actually take the time with you.
Wonderful advice. Thank you, Susan. I think we'll finish up with one last question. When it comes to these topical treatments, do you recommend anything different for women that are pregnant? Are there any concerns there?
That's a great question. Actually, topical steroids can be used safely in pregnancy. Very often, skin will completely clear. It's either going to go one way or the other. It's going to be really bad or it gets really, really good during a pregnancy. I've heard it both ways. But use of a topical steroid is safe in pregnancy. I generally tell my pregnant women that in the first 3 months, so that first trimester of pregnancy, it's better if you cannot use anything. That's the most critical time in your pregnancy. And then usually after the first trimester, other topical treatments for other skin diseases, I'll give the go-ahead on that. But topical steroids are very safe in pregnancy. And just obviously having the discussion with your OB/GYN, but they're not contraindicated.
Wonderful. Thank you again, Susan, for helping us to understand how to treat eczema and atopic dermatitis with topicals.
You're welcome.
The National Eczema Association would again like to thank Aqua Pharmaceuticals for their sponsorship, which made today's webinar event possible. We also want to encourage you to get involved with the National Eczema Association and raise awareness about this disease. There are a lot of ways you can get involved. You can become a NIA ambassador, working in grassroots advocacy, joining our online support group Eczema Wise, and more. You can attend events. Our Leaders in Eczema Day-Long Forum will be held on October 1st at Mount Sinai in New York City. And you can save the date. Our 3-day patient conference will be held in Chicago, June 22nd to 24th, 2018. And of course, you can donate. As a 501c3 nonprofit, our work relies on the support of our community. You can also learn more about all of these opportunities, as well as many eczema resources on our website at nationaleczema.org. If you submitted a question today that wasn't answered, I highly encourage you to go to our website and check out the resources there, as many of the answers are in fact already on our website. On behalf of the National Eczema Association, thank you all for attending our Treating Eczema and Atopic Dermatitis with Topicals webinar. And thank you again, Susan, for your wonderful, wonderful presentation.
You're welcome.
Have a wonderful evening.